good morning, good afternoon, good evening, everyone. As mentioned, welcome to this week's IFA Global Café. My name is Roxana, and I'm very pleased and excited to be moderating today's discussion with the incredible Dr. Kathy Pechora-Fuller for the topic of making ear and hearing care a reality for older adults. So as a little bit of background for everyone, Dr. Pechora-Fuller is currently a professor emerita at the University of Toronto and an adjunct professor in gerontology at Simon Fraser University. Her basic research program concerns auditory aging, and her clinical research concerns audiological rehabilitation for older adults. She's really earned an international reputation for her interdisciplinary approach in linking research on auditory and cognitive processing during communication in everyday life. Kathy has worked for several years as a clinical audiologist, and she was also on the faculty of the School of Audiology at the University of British Columbia and a guest professor at Linköping University in Sweden. So amongst many other positions and achievements, Kathy is the hearing expert for the Canadian Longitudinal Study of Aging and has served as a member of the sensory cognitive team of the Canadian Consortium on Neurodegeneration in Aging. Ultimately, she really translates her lab-based research on auditory and cognitive aging to address the needs of older adults who suffer from both hearing and cognitive impairment, with a new focus on social engagement and healthy aging. So it goes without saying that Kathy's experiences, her achievements, and her background positions her as really an ideal expert for today's topic. And we're very excited to have you with us. So thank you. Before I dive into some questions, I just want to remind and encourage folks again to please type questions or comments in the chat function for our key expert today to really just feed this interactive dialogue and discussion today. So now I guess we can start a little bit to talk about your background again, Kathy. So as career choices are often based on life experiences, what prompted you to go into the field of hearing health and audiological rehabilitation for older adults?
Well, I'm just sitting here looking at all these faces. I think I actually recognize the names of some people who live with hearing loss, who I have worked with as patients. I see a lot of colleagues. And what are we doing? We are communicating, and I think I have always been fascinated by communication, but communication is, I think, par excellence. This is the human behavior. So we are all here, it's 4 o'clock in the morning, and I am here trying to communicate with all of these people. And I think really that was kind of always fascinating to me. When I was in about grade 3 and my sister, was learning German and French, and she had her grammar books. It's like, what is that? That's magical. And I tried to make up my own language, and I had a secret writing. And my son did that too as a child. And I think we all have this kind of fascination with, well, if Martians came to Earth, how would we talk to them? So we're social animals. Health relies on us being socially connected. I studied language and literature, and then it's like, well, what if you couldn't communicate? Yeah. And this is what speech pathologists and audiologists are trying to improve in people's functioning, is this really, really core beautiful thing that humans do to communicate. So I learned a lot about how people live with hearing loss from my patients. You always learn more from people than you do from books. And the path that I've taken over the years, I think, is like, people need help with this. How could we help them better? And that kind of led me from hearing as a focus to cognition. And then I would say more recently, my interest in gerontology is like socially. So when people leave the clinic and they have to go home and they have to go to their workplace and they have to go to their community centers, how do they actually do that if they have a hearing loss? So I kind of see I've gone from being interested in sensory communication and then the linguistic and cognitive side, and then ultimately, the real frontier is the social side, and that is so important for aging.
No, absolutely. And thank you very much for that. I think that was a great way to kind of communicate that hearing really is communication, and it's such an important element in everyone's life, regardless of age, really. Switching gears a little, can you speak to us a little about the relationships amongst combined sensory and cognitive impairments and the associations with health outcomes in older adults?
Well, I think this is also a fabulous era of health, especially for older adults, where we are finally getting out of our silos. So the old medical model where people were conceived of as different body parts, and the ears were the ears and the eyes were the eyes. Recently, my colleagues and I have done a chapter for a geriatric medicine textbook, and we said, no, we are not having separate chapters for vision and hearing because they work together. So now we have a chapter on sensory aging, and we have put together hearing and vision. So I think, it's not just about hearing. What I want everybody to think about today is how you can't do very much at all without your senses, with hearing, with vision, even the other senses. How would you enjoy your dinner if you couldn't smell or taste? So we don't usually think about these things, but hearing is connected to everything for many people. And I am very aware that people who are totally deaf, who may use sign language, they are relying on vision instead. So I totally acknowledge that. But the WHO has done some amazing work in the last couple of years. I probably you've had some sessions on this idea of ICOPE, integrated care for older people. And what the WHO has identified are 6 key capacities. And it's hearing, it's vision, it's cognition, it's mental health, it's nutrition, it's another thing that they call different things that sometimes they call it vitality. It involves cardiovascular sorts of things. So hearing is right there, needing to be integrated. But of all the things on that list, people are very well aware of mobility. I think people are more aware of vision, but people almost never think about hearing. Hearing is the most prevalent impairment in aging, and vision is closely following it. So between the two of them, the majority of people, once they get into their 70s, are going to have some kind of a hearing loss. And yet it is the most forgotten. So hearing loss is sometimes called the invisible handicap, and the acoustical environment is sometimes called the invisible environment. So we're kind of ironically making hearing visible today. And this is in anticipation of World Hearing Day. So hearing connects to what? Well, it connects to physical health issues in aging that affect functioning. Falls. Falls is an enormously important problem, but hearing will actually increase your risk of falls. How do we combine hearing rehabilitation with falls rehabilitation? Hearing connects to psychological changes. So there are connections to depression. There are really, really important connections that we're studying to dementia. And I think, physically, psychologically, socially, there is also very, very compelling, important place of hearing and vision for social health. So loneliness and isolation, and I was listening yesterday to a webinar about social prescribing and how, doctors are now recommending that older adults engage in activity to try to make sure that they do not become socially isolated. And it's like, well, how would you do that if you couldn't hear? How would you go to the local community center? How would you engage in an activity? So physically, psychologically, socially, you really can't get very far, and you can't really participate, and you can't really function if you can't communicate. And it's really hard to communicate if you can't hear well.
Yeah. No, absolutely. Thank you for sharing that with us. You mentioned dementia in that as well. And looking through the chat, I see Mr. Dominic Boyd made a comment as well as a question with dementia and hearing loss as well as long-term care. Dominic, would you like to unmute and pose your question if you like?
Yeah, thank you. I got excited when I saw that we were going to have this workshop today, because back in the 80s, I worked in a long-term care place as a social worker. And I went to a conference that there was a woman there speaking about the need for adequate ear care and hearing care. And I realized that we didn't have any way of really monitoring the residents' hearing, functioning, and health. And so one of the staff from the audiology program at Dalhousie University was willing to come and bring her students. And they tested there were 180 residents. They tested as many as they could. They checked on hearing aids. They had ears cleaned and so on. We had 2 doctors who came and saw the residents, and those doctors weren't looking after their hearing care. It was just completely not on the map. So I thought I'd mention this. It was something I was passionate about. I no longer work in that field, but I'm curious as to what you know about long-term care in Canada, and how is hearing care and hearing abilities, how are they looked after? How well are they looked after these days?
Oh, well, I am very happy that you asked that question. And I can see faces on the screen of some of my colleagues who are pioneers in this. So maybe they'll get into the discussion too. But let me just kind of take off from Roxana's comment about dementia. So some of my colleagues that I work with in the Canadian Consortium on Neurodegeneration and Aging, we use data that is collected from many of the Canadian provinces using the Inter-I, which is used around the world, for home care and long-term care. And some of our publications, I'm happy to share them, show that people with combinations of vision loss, hearing loss, and cognitive loss, they're functioning, and their quality of life in long-term care and in home care is seriously affected by that combination. And we also have papers showing that people who are newly diagnosed with a sensory problem are more likely to go into long-term care. So these combinations, sensory problems are parts of frailty. And, there are huge implications for how we provide all kinds of primary care, home care, long-term care. And the projects that I have done in my own experience actually came from seniors. So the first project I did in a long-term care, first time I'd ever been in a long-term care, it was in a town called Dundas, Ontario, near Hamilton. And the Hamilton Wentworth Seniors Council had asked for hearing care in long-term care. I had a similar experience in Vancouver, where the Seniors Council to City Hall initiated, this was a citizen-led project asking for hearing care in long-term care. And we have had projects. I'm going to mention you, Brenda, because I see your face on the screen. So Brenda Lucen, who's here, was the pioneer who developed hearing care for the veterans at Sunnybrook. And we have colleagues who do beautiful work at Baycrest. So people want it, people need it, we know how to do it, but it can't just be in, specialized cases. We have to generalize it. And that is actually a topic that many of us are working on now. So some of you will know that in Canada, we recently had the release of new standards for long-term care, both on the Canadian standard side that gets at things like the technology and the physical environment, and on the health standards, which get at behaviors and ways of doing work in long-term care. And to our total delight, we made recommendations for hearing care and long-term care, and many of those recommendations are in the new standards. So, they took verbatim some of our recommendations and put them into the new CSA standards for long-term care. And, there are not a lot of audiologists in Canada. There's a few thousand audiologists. So, you cannot have an audiologist in every single long-term care in Canada. You couldn't have a physiotherapist or any of the other rehab professions either. So I think the challenge for us, the interesting discussion now, is how do the PSWs and the nurses who want to be able to communicate better, and they want to be able to support families and residents to be able to function, and communication as part of that, how do we connect the rehab professions so that the people that they're living with in their everyday life actually know some pretty simple tricks that go a long way. And I think that's another beauty about communication is hearing aids are expensive, but hearing aids are not pills. And there's actually an enormous amount that can be done by changing behaviors, by changing things in the environment, and anybody can communicate. Any PSW is a communicator. Any nurse is a communicator. Any doctor is a communicator. And I'm just so excited that now we're in an era where we're going to have, I hope, some good interprofessional sharing, and we can support each other and share some of these tricks and make every single person in healthcare more savvy about the little tricks so that people with hearing loss don't get excluded. So I don't know if that helps you, Dominic, but I'm really optimistic that we're going someplace finally, and we sure need it. And maybe that's one of the kind of ironies of COVID is that things that we've known for a long time, we've been working on this for decades, but maybe it's finally going to happen.
Thank you very much. Appreciate it.
Well, thank you both, Kathy and Dominic, for your question. Kathy, you raised the point of behavioral rehabilitation. So with increasing age, there is a tendency to dispense an aid rather than undertake careful screening and assessment of hearing to then determine the most appropriate management to both maintain and improve hearing-related health outcomes. Now, with this and the idea that hearing aids are the main viable solution to hearing loss, can you speak a little about other interventions and the benefits of behavioral as well as non-technological rehabilitation, please?
Mm-hmm. Well, let me just say that over decades, there have been vast improvements in hearing aids. We now have cochlear implants. And there are centenarians who are out there flourishing and getting on in their life because they're able to take advantage of those technologies. So I kind of feel like been there, done that. Audiologists know how to deal with hearing aids, and ENT doctors and audiologists, they know how to do cochlear implants. But it's it's the non-technological side that is actually, in my view, the real art of the business, and everybody can communicate. So what is it that would make the life of an older adult with hearing loss better? And, it's things like looking at them, making eye contact when you talk to them. So how many times have I been in a situation where somebody is taking somebody in a wheelchair and they grab the wheelchair and whisk them off to go to some clinic, and they have not stopped and just looked the person in the face and said, all right, Mary, it's time to go see Dr. So-and-so, here we go. Are you ready? And, preparing the person for what's going to happen and providing them some context and involving them in what is happening. So, it's something as simple as, 10 seconds of just, making that contact with somebody so that they don't get, somebody with dementia does not get agitated because they don't know what's happening. So there are very, very simple things. I was in a medical clinic this week, and it was an ophthalmology appointment. So I'm having my eyes checked. So I'm very interested in how people in the ophthalmology clinic are possibly having hearing loss too, because people with vision loss are more likely to have hearing loss when they're older and vice versa. And here is a large waiting room. There's probably 30 people in the waiting room. They're being called by an army of technicians to see, multiple doctors. And somebody comes out with a piece of paper and says, Mary Smith. And everybody in the waiting room is in a panic because they're waiting to be called and they don't know who's being called. Something as simple as, how do you call somebody in a waiting room? So these things are not expensive. These are just small behaviors that make a huge difference. And now we're thinking about, what would hearing care look like in primary care? What would your family doc need to know so that he could improve the experience of somebody with hearing loss who was coming to learn about diabetes or cardiovascular problems or a plethora of things that family docs are dealing with, but people also happen to have hearing loss, even if they've got arthritis in their knees and they need to be going for knee surgery. Why do people go to the hospital to have knee surgery as an outpatient for the day, and they are told they have to take off their hearing aid? So they get to have no knowledge of what is going on during a procedure like that. It is just actually cruel and very stressful not to understand how to accommodate people who already have technology. There's a little gadget, which is, pretty cheap and cheery, called a pocket talker. And I was so excited recently because at Mount Sinai in Toronto, I could see Samir Sina's group, who was the leader of the long-term care reforms on the HSO side. He now has a summer course for students who might be interested in geriatrics to learn how to use these little devices to talk to people. So if you might have dementia and you're going to go and have a cognitive test, are you going to remember something that you didn't hear or see properly? No. So there's this kind of problem with the accuracy of these tests if they're not actually conducted in appropriately quiet and well-lit conditions. And if people don't have their glasses and they don't have their hearing aid, or they don't have one of these other amplifying devices that would make it possible to at least give them their best chance when they do a cognitive test. So, you know, the list goes on, but I guess the message that I want to get across is these things are not expensive to do, and small, it's a difference that makes a difference. And our colleagues in Montreal who look at stress and aging and how that affects medical encounters, in their work, they actually recognize that people with hearing loss have a lot more stress in any health condition. So how can we reduce that stress? Because stress is not going to be good for any kind of healthcare. Anyway, I could go on, but I think you get the idea.
No, thank you very much for that. It really resonated with me when you said a difference that makes a difference. I think I'm going to keep that in mind as well.
I would also say that, you know, as people get older, in midlife, people, I'm looking at the faces on the screen, and I bet most of the people on the screen here are like my husband. And he used to love to go to the pub and have a beer with his friends. And now he thinks twice about it because it's noisy and it's kind of annoying and not enjoyable to do as something as simple as go to the pub and have a beer with your friends because it's too noisy. So this is usually the first experience people have is, I don't want to go to that party because it's just going to be noisy and it's going to give me a headache and I'm not going to have fun. So things that used to be fun aren't fun anymore. And these are this problem in noise. It's a problem of clarity. Some people need sounds louder. Some people need amplification, but it's really in the early days, it's more about noise as an environmental challenge that creates this pathway for people to withdraw. So, you know, there are things in the long-term care standards, there are acoustical factors that are considered. How do you choose a restaurant where it's going to be quiet? You know, how do you do things like go to the pub in the afternoon before it gets too crowded? So these are the kind of how do you live your life with a hearing loss? That is part of hearing rehabilitation, not just technology. And actually, it's really important for people before they would even be candidates for a hearing aid. And those are the kinds of patients that I saw in the clinic. It's like, well, I can get this hearing aid and it's great watching the TV and it's great talking to my wife in the living room, but I still can't go to the theater. I still can't go to my business meeting. I still can't. And that's what drove me to go back and do a PhD and try to figure this out. And I think we're getting somewhere. So let's just do it.
Thank you for that. So in late January of this year, the WHO considered the report on strengthening rehabilitation and health systems, which was actually kindly brought to my attention by a colleague last week. And in the report, it was noted that persons in marginalized or vulnerable situations often lack access to affordable, quality, and appropriate rehabilitation services and assistive technology. This goes off a question that was posed in the chat by Mr. Shmuel Gevrulshami. My apologies for any mispronunciation. And Kathy, if you're unaware, we're very fortunate to have Mr. Shmuel. He's a very consistent supporter of IFA Global Cafés, not only as an attendee, but as a contributor through very insightful questions. So he posed the question regarding hearing care and low socioeconomic groups and populations. Can you speak a little about perhaps the additional barriers to accessing ear and hearing care interventions that marginalized or vulnerable community members, including low socioeconomic groups or populations, may sometimes face?
Well, I think I also, that was a pretty recent WHO report, and I was very happy to read it. So, and I think the basic theme is we need rehab. You know, this is the era of rehab. And it's audiology. Audiology is always left off, even though hearing loss is the most common impairment. Even when there are physiotherapists or occupational therapists or even speech pathologists, audiologists are the last ones to the table, even though they have really excellent solutions for a very large number of people. So I think just having people with the knowledge that a rehabilitationist would have is, even in Canada, we do not have enough audiologists to be able to connect them to every primary care practice or every long-term care. So how are we going to do this? And I think one of the concepts of the WHO that's really important is this idea of task sharing. And I do not see hearing care as, the sole domain of audiologists. I would like every single health professional, every person who works in the healthcare system, the ladies in the cafeteria who are serving food, anybody who works in healthcare should understand about communication accessibility. And some of the things that will go a long way are not costly. Actually, if you do look at some of the reports that have been done, actually providing hearing care and attending to hearing problems is a cost saver for the healthcare system. You can imagine this. Instead of repeating something 3 times, you only have to say it once. People don't make mistakes understanding their medications. It doesn't take a lot to imagine how actually ensuring that people hear and that communication is successful and positive would have huge savings in the healthcare system. So I think we have to kind of put a new lens on the economy. And instead of saying, well, hearing aids are expensive, well, hearing aids aren't necessarily expensive anymore. Our colleagues at Johns Hopkins fairly recently finally have had published in the Journal of the American Medical Association a paper showing that a project that they call HEARS, which we have also, our colleagues in Canada have replicated in Ontario and in New Brunswick. It's basically designed for lower socioeconomic class people who would never come to the hospital. They would never buy a hearing aid. So we do they don't call it this, but I call it street audiology. So they go to the community centers, they take their knowledge to the community center. It's a lot of education. And now we have over-the-counter hearing aids, OTCs, people might have heard about in the news. We've always had them, but the difference now is that they're regulated in the US by the FDA, so that at least a consumer has some confidence that the products work, instead of having like some of them are great and some of them are terrible. At least there's a standard now. So they basically use these very, very affordable amplifiers and education, and they had positive outcomes in terms of people benefiting from them in their everyday life. So if we just had this idea that everybody can participate in improving the lives of people with hearing loss, it would be possible to do, and it would not be expensive. It could actually save money. One of the other things, which is a huge barrier to people help seeking for hearing care, is stigma. Cost is not actually the barrier. If we look internationally at countries where people are given hearing aids for free, people still, only about 1 in 5 of people who could wear a hearing aid actually even get to the door of the clinic. And cost is non-trivial, but the real barrier is stigma. So why does it take 10 or 20 years between when somebody first notices a problem and when they actually say, I need help with this hearing? And this is an attitudinal thing, and it's bundled up with ageism, which is a topic that IFA is very involved in. It's like, I don't want to get a hearing aid because then I'd look old. Well, let's think about that one. I'm too old to get a hearing aid. Let's think about that one. So some of the interventions that my research is focused on now are actually about breaking down some of the self-stigma and some of the social stigma about hearing loss. So I think things like age-friendly, all the age-friendly initiatives should be hearing accessible.
Yeah.
And yet when I have talked to people high up in Public Health Agency of Canada who are promoting the idea of age-friendly communities. And I say, well, what about sensory accessibility? Could I go to the local senior center and do Tai Chi if I couldn't hear the instructor? My colleagues who do vision, I'm just amazed. They have in Montreal, I have to go see this, people with vision loss for whom they have enabled them to do curling, so have we thought about participation in hearing loss? Are people with hearing loss even involved in some of the consultations about age-friendly? So when I ask a question like this to people who are leaders in age-friendly, what about sensory accessibility? They tell me about wheelchairs and how their facilities are wheelchair accessible. And then I'm told, well, we're in health and the people who do accessibility are in a different department. So yeah, maybe we should get together. So I think, again, it's this crosstalk. Like, I'm so happy that when they did the long-term care standards reform, that they had the engineers and the doctors talking to each other. So I think, if society changed and if people's behaviors changed, and if we just did a few little things that would make communication accessibility real, it would benefit everybody. Yeah. So again, I'm very hopeful, this is not a big budget about buying hearing aids. Our colleagues in the US, where they don't have a lot of coverage, they're self-paying for a lot of their health care, certainly hearing aids. So of all the countries we've studied, cost is the biggest issue in the US. And they got these OTC hearing aids approved. They have affordable alternatives. They've done the research to show it works. But the real emphasis is on the personnel. So how do we train more rehabilitationists, and how do we connect the rehabilitationists and get them out of their silos so that they can help all the other health professionals do a better job?
Well, thank you very much, Kathy. Actually, just building off of your point on stigma there, while I was reading through the chat, I saw Francis Wilkinson raised a question regarding stigma as well. So Francis, if you don't mind, would you mind please unmuting to ask your question?
Hi, Kathy.
Hi.
You sort of already answered what I said, but I just was commenting that stigma seemed to be a huge thing with hearing aids, and it isn't so much for glasses, although at one time it probably was. And I'm really curious whether you have any thoughts about what is the best way for us to communicate or convince sort of the younger, older people, the ones that are starting to develop hearing loss, that they really do need to get their ears tested, and there's nothing terrible about this.
Mm-hmm.
I mean, I'm one of those people that knows this and hasn't done it myself yet. So I think it's very common.
Well, the World Health Organization released the World Hearing Report a couple of years ago. We are coming up to World Hearing Day on March the 3rd. The theme for this year is Hearing Care for All, which is reflected in the title of my talk today. And they have prepared fabulous materials that are going to be released for World Hearing Day, focused on hearing care in primary care. And their messaging is that 60% of ear and hearing care can be done in primary care by people who are not, don't have graduate degrees in audiology. These can be done by community health nurses and physicians and people in primary care. And in the World Hearing Report, they recommend, and this resonates in this other WHO report on rehab that Roxana was talking about, that hearing screening be universal across the lifespan. We already have hearing screening for babies, but for me and for you, what they recommend is that starting at the age of 50 in primary care, hearing screening should happen for every person starting at the age of 50. And we've had a group of us in the US, Canada, Australia, and the UK have done a big NIH funded project in 4 countries. And we've asked people, not people in the clinic, people who are recruited from the community, some who do not yet have hearing loss, some who do have hearing loss but haven't acted on it, some who have acted on it and are happily wearing hearing aids and have had rehabilitation. And what they all say is that they want their hearing care to start in their family doctor's office. They want the family doctor to be able to say something intelligent to them when they start to mention that they have concerns about their hearing. A lot of family doctors don't know what to say. Even my own family doctor, when I hit 50 and it came up on his menu that he should ask me about my hearing, how's your vision, how's your hearing? I said, well, I do happen to know what my hearing is like because I could have it tested any day in the lab. But just out of curiosity, if I told you I didn't think my hearing was so great, what would you do? And he said, oh, I'd send you for a hearing test. And then there was a pause. And then he said, unless you didn't want a hearing aid. And I said, okay, 2 out of 3. I'm for you. And I think they don't know. They don't know what to say to people. So I really think this is going to be a great World Hearing Day because, the WHO is putting materials in their hands so that they know what to say. And I think that there was a time, even last week, I was talking to people who were trying to do remote care in Saskatchewan with dementia in mind. And they know that hearing is part of how do you live with dementia. And it's like, well, you're going to do this remote care. What about hearing? They say, oh, well, we can't do hearing because you have to have those machines. And it's like, not anymore, because the WHO, oh, this is so brilliant. They have an app. It is for free. You can download it today. You can test your own hearing. In the summer, they revised it so that you could direct your results to a health provider of your choice. You can keep your own longitudinal records of your hearing. It's just a screening test. One of the main innovators behind that is from South Africa. And they are able in South Africa, in places where, they do not have sophisticated healthcare options, on a smartphone, people can do hearing tests. People can have remote hearing care. And so we're in a great time because basically it takes 3 minutes and it's for free. Like, how can it get better than that? And I have spoken to some people in the Ministry of Health here in British Columbia at a scientific event, but where there are economists, who are eager to implement e-health options that could be beneficial. And I say, well, what if I told you the WHO had a free 3-minute hearing test? Would that appeal to the Ministry of Health to include it in their e-health initiatives? And he was very positive. So I think if it was just normal to have a hearing test, just like it's normal to have your blood pressure test. Our colleagues at Johns Hopkins have a little paper that's kind of cute in JAMA that says everybody should know their number. So they are advocating for hearing screening. And if you go through the WHO guidance on hearing screening, like you have your hearing test, you open the conversation, but then you also have a chance when people are middle-aged to do health promotion and to give them advice and to inform them about where should they go when they have problems. you open the door. So this is going to recur, whenever they're up for their regular health checks. And it's just going to be normalized. And then if you knew when you were 50, that you were starting to have a hearing loss and you were starting not to go to the pub and have a beer anymore, and maybe, had to find another way to meet up with your friends, maybe you actually would not have so many health declines. And then when you got into home care, it wouldn't be a big surprise. What do you need in order to be able to communicate with the person who's coming to give you a bath? When you got into long-term care, it wouldn't all of a sudden be like, oh my God, nobody knows if this person has a hearing loss or a vision loss, or have they got the up-to-date information on that. So like what Dominic said, it's just like, it is way too late when people enter long-term care to start thinking about testing hearing. If we start when people are 50, it just won't be a surprise. It'll be normal. I met a geriatrician in Mississauga once, and she said her vision of geriatric care was 967-1111. And for those of you who live in Ontario, you will know that is the phone number of Pizza Pizza. And in those days, if you called Pizza Pizza, they'd say, oh, well, hello, Mrs. Fuller, and will that be your usual? So her vision of geriatric care was, it would just be in your record and everybody would just know how to accommodate for your needs, be it hearing or anything else. So that's what I'm aspiring to. Would that work for you, Francis?
Well, thank you very much. We have a very packed discussion in the message chat, actually, and we have a question from Brendan Sherlock. I'm so sorry for missing that previously, but can I please ask you to unmute to pose your question regarding data and geographic location?
Yeah, my question would be, does it make a difference as to where people live, say in an urban or a rural setting? Because I find that people who are in enclosed places, their hearing, to me, is always a little bit less than people who live, say, in the country. Now, maybe it's just me, but it might be an interesting avenue to proceed to. Does it make a difference if you're out in the air, if you're out in the country, as against being in cities, towns, and constantly embroiled in noise? Saying noise as being the general, everything, language, the whole lot. Thank you.
Oh, well, we could talk about that for a long time. So I think environment is, the person environment match is a big theme in aging. And I more and more, especially now that I'm getting older, I feel more like my environments are getting more hostile. It's not me, I'm changing. Yeah, I guess I'm changing. But, all of a sudden, if it's noisy, that's an obstacle. So noise could be outside. But I think if we, measured the decibels, if I go for a walk in the park, it could be noisy if it's right beside a big highway, but it's probably quieter. I think this is the appeal of parks, is that you do have a quiet space and it is a good place to talk. When you get in a room, rooms have reflections. And architects, sadly, a room could be visually beautiful, but acoustically horrible. And I'm sure every single one of you has been in a room and it's a nice room until everybody comes, and then everybody's raising their voice and everybody is getting a headache because reverberation, these echoes from the wall, are terrible. But these are things that acoustical consultants can manage. So I think that's another kind of opportunity we have, is now we have acoustical standards for classrooms that came in the 90s. And following on that pathway, now we have acoustical standards for healthcare environments. Some of the new designs for long-term care, acoustics is very important. So, the first long-term care project that I ever worked in, it was a facility run by nuns, and these nuns were terribly insightful. They created like a quiet room. And So if somebody wanted to have a family conversation, they could go to this quiet, private place. So I think the outdoors has that value to people. Let's go for a walk. Let's go to the park. I think maybe people who are living in rural or remote areas have had less noise exposure. They may have more opportunities to find quiet spaces. They may also be more physically active. And physical activity, as you know, is very good for your cardiovascular system and very good for your brain. And actually, it's very good for your hearing too, as a form of prevention. So if you look at the WHO World Report on Hearing, you know, what can you do to not lose your hearing? You know, avoid noise, don't smoke, do physical exercise that is good for your cardiovascular system, because that in turn will be good for your auditory system. So I think that people who live rurally, you know, they may have a better ecology in terms of their auditory life. But I don't know of any studies on that exactly. But I think the kind of larger theme is it's the person in their context. And it's not just all about, you know, did you hear that tone? It's about, well, what do you want to do with your hearing and where do you want to do it and who do you want to do it with? Get to the functioning.
No, well, thank you very much, truly. Our chat is very full today, and I think we might have time for one more question, and that is regarding lip reading and hearing loss. So I know Mr. John Peters posed a question. If I can ask you to unmute, Kathy Olenix, I'm also very, you know, appreciative of your comment related to lip reading and COVID. So if you could mention that afterwards as well, after John Peters' question, that would be great. So John, can I ask you to please unmute?
Yes. So my question was, and I became early on, that's why I started using hearing aids. I became aware that if people turned away from me, I did not hear them as well as when they were facing me. And I asked myself, am I unconsciously reading lips? And I'm wondering, my question was, if that is so, if we do it somewhat naturally, are there ways that people with hearing loss can learn how better to use lip reading as an aid to hearing?
Well, that is a great observation. And that is one of the things that fascinated me, you know, people who could communicate if they were looking at you, but as soon as they were looking away, basically they didn't even know you were talking. Probably a little bit more extreme than what you're talking about, but absolutely. So hearing and vision are very, very tightly coupled in communication. You know, it's harder to talk to the person in the backseat of your car, right? It's harder to talk to somebody in the dark. Every single person, even young people with perfect hearing, lip read, because your brain just wants to put all that information together. And some of the things that are easy to see are hard to hear, and vice versa. So there's a natural kind of partnership that you get the most information when you combine vision and hearing. You understand faster if you combine vision and hearing. You are more resistant to the effects of noise if you're lip reading. Everybody lip reads in that pub when they're drinking the beer because, you know, all the people with hearing loss that I know, they love to go to a noisy bar because they turn their hearing aid off and they can lip read really well. And they say that's one of the environments where they have a leg up on the people with normal hearing. So the brain is a fabulous adapter. So people who in their lifetime do not have auditory input, you know, their visual system actually takes over the territory in the brain where the auditory system would have normally, you know, been operating. So your brain actually, you know, as you adapt to these sensory problems. You know, the brain is actually changing how it processes information, and it is something that you can train. But this isn't exactly, you know, it doesn't require a graduate degree to get the key points about speech reading. So some of the famous people who have spent a lot of their research career studying speech reading, when they get to working with patients, they say, well, rule number one is look at somebody's face. And just looking at somebody's face is not something that everybody does. So I've done a lot of rehab classes where it's like, no, you're never going to understand your wife if she's talking to you with her head in the refrigerator. So just take your head out of the refrigerator and turn and look at the person, and bingo, hey, it's better. And these are routines, you know, that you develop with your significant others, is to optimize all the information.
Yeah.
Lighting is very important.
Thank you very much, Kathy. And I mean, Kathy Olenek in the chat also just made a great point of how we rely on facial cues and lip reading, and especially since the COVID pandemic and the need to wear masks. So thank you very much for that comment. But
I just have to say this. So masks, absolutely. But, you know, thank goodness that Zoom is a normal thing now. And when I think about e-health and all of the doctors' encounters that people are having online, this has been a fabulous opening for people with hearing loss, because they can speech read on Zoom and they can have captioning. Yeah. And, you know, if I could wave my magic wand tomorrow, nobody would do telephone calls as part of their remote health. It would all be audio-visual, and that would be amazingly accessible to people with hearing loss.
Thank you very much. Now, coming close to the hour, I just want to highlight that this really does cap an important and timely topic of drawing attention to hearing health for older adults, particularly relevant since World Hearing Day is just around the corner on March 3rd. So thank you, Kathy, and thank you everyone for the discussions today. Just before jumping into the key takeaways from you, Kathy, I would like to introduce our next week's topic and speaker. So next week, we have the opportunity to speak with Dr. Leon Jeffin for the topic of leadership in long-term care and models to support older people who live in resource-constrained countries and communities. So everyone should, it's going to be an incredible discussion, and I can't wait to hear that next week. But back to you, Kathy. In a few sentences, may I ask you for your key takeaways today?
Well, I think we started off with communication, and hearing loss is a little different from some other disabilities because communication has at least two people. So there are people with hearing loss, but there are the partners of people with hearing loss. And everybody here on the call, you may or may not have hearing loss yourself, but you are a communication partner, you know, over the course of your day with people who may have various degrees of hearing loss. So it takes two to tango. And there is, to hold up, you know, your end of communication, there's a lot you can do, and just even being mindful of it and asking the other person, you know, if there is anything that would help them, and being open to discussing how to make it easier for somebody. People will give you some, will be happy to be asked, and you can all do better. So let's just communicate as well as we all can.
That's a great note to end on. Thank you very much. And thank you everyone for joining. Have a great rest of your day. Take care.